Welcome to AETCM, the emergency medicine channel. Today let us discuss about hypokalemia and its management in emergency room. Potassium is a major intracellular cation. We know that potassium helps in our muscle activity. So it is very important for the contraction of muscles or muscle strength. Normal potassium concentration in our lab will be 3.5 to 5 milliequivalents per liter. So when the potassium levels are low in our body, it can be reflected in the serum levels also. Normal daily intake of potassium will be 1 milliequivalents per kg body weight. So around for a 75 kg patient, it has to be 75 milliequivalents per day. So when we are correcting hypokalemia, we have to always keep that in mind, that so we have to calculate the total deficit, and we also have to replace the daily requirement, because in patients who are in ICU, emergency room, all these patients may not be taking oral feeds correctly. So when we have hypokalemia, we have to always think that the total deficit has to be calculated, that has to be corrected, and we have to also remember that this patient has a daily requirement. Hypokalemia is defined as potassium levels less than 3.5 milliequivalents per liter, and moderate hypokalemia less than 3, severe hypokalemia less than 2.5. So diet gives around 120 millimoles or milliequivalents per day. Daily requirement will be around 1 milliequivalents per kg per day, and the absorption is from the gut to the ECF. It contains around 2450 millimoles. ICF contains 375 millimoles. From that, loss will be mainly through sweats. Sweating may lose around 10 to 15 millimoles per day. Millimoles and milliequivalents are almost equal. Through stools, around 5 to 10 millimoles per day. So if there is an increased sweating, increased stool like diarrhea, patient can lose large amount of potassium. Vomiting also loses large amount of potassium. In kidneys, some are reabsorbed, some are removed from the body. Around 100 millimoles per day is removed. So the requirement in the body is around 75 milliequivalents per day for a 75 kg person. Around that much is removed every day. So it's mainly, we are getting potassium mainly through the fresh fruits or vegetables, so that will maintain our muscle strength. Hypokalemia has got various causes. It can be due to, we have seen how the potassium is losing from the body. It can be due to renal loss or extra renal loss, or another mechanism, that is transcellular shift, a shift in between intracellular space to extracellular space. So shift can happen to either side, so that is transcellular shift. And last one is decreased intake, dietary, patient is not taking adequate potassium. So if the patient is not taking adequate potassium, then patient can have hypokalemia, especially in elderly individuals and all. We can get hypokalemia due to dietary deficiency. Extra renal cause we have seen from where we are losing potassium, through sweat and GIT, vomiting, diarrhea, increased sweating, laxative abuse. All these things can produce extra renal loss of potassium. Renal loss of potassium is, various causes are there. So one of the important cause will be like patient is having kidney disorder, which in that type of kidney disorder, patient is unable to concentrate or reabsorb potassium from the kidney. So there are various conditions like that. One of the most important condition will be Conn syndrome. So that we will see afterwards. And Bartter syndrome, Gentleman syndrome, renal tubular acidosis, diabetic ketoacidosis, nephrotic syndrome, acute tubular necrosis, celiac disease, tropical sprue, villus adenomas, hypomagnesemia. That is very important, because any patient who is having hypokalemia and renal loss of potassium, we have to always rule out hypomagnesemia, because unless until you correct hypomagnesemia, you will not be able to correct the hypokalemia. So that is very important. And transcellular shift is another important factor in hypokalemia. primary hyperaldosteronism, drugs like insulin overdose, diuretics, familiar or sporadic periodic paralysis, barium poisoning. In that periodic paralysis is very, very important. In periodic paralysis, what happens is transcellular shift occurs due to high carbohydrate diet. So when the patient takes high carbohydrate diet, the potassium will be shifted out of the intravascular compartment. So acutely patient develops hypokalemia and muscle weakness. Now this is called as redistribution of potassium. You can see here extracellular fluid 2% of the total potassium, intracellular fluid 98% of the total potassium. So some drugs like insulin, beta adrenergic stimulations, alkalosis, all these things can shift the potassium from the extracellular space to intracellular space. So insulin can acutely shift the potassium to the cells. Acidosis, plasma hyperosmolality, alpha adrenergic stimulation, exercise all shift back the potassium from the intracellular space to extracellular fluid. So this is called as transcellular shift of the potassium. So if there is a problem in this transcellular shift, sometimes they are called as channelopathies. Suddenly patient develops muscle weakness due to sudden shift of the potassium from the extracellular space to intracellular space, and intravascular potassium levels or serum potassium levels will be acutely reduced and patient develops acute muscle weakness. So bilateral flaccid paralysis, one of the important causes hypokalemic periodic paralysis. Hypokalemic periodic paralysis means there may be family history, it can occur periodically, repeated attacks can be there, then hypokalemia will be classically associated with that. In hypokalemia, most of the time the reason may be high glucose diet. So you are seeing here insulin can shift out the potassium from the extracellular fluid or intravascular fluid. So same like that, high glucose feed also can shift the potassium. So metabolic alkalosis can shift the potassium. Drugs like salbutamol, terbutaline, dobutamine all can shift the potassium. Insulin and glucose both can shift the potassium. Insulin and glucose or glucose alone can shift the potassium to the cells, and intravascular potassium will come down. Hypokalemic periodic paralysis is a channelopathy. In that patient develops acute paralysis. Often it is precipitated by exercise, stress or high carbohydrate meal. Non-renal loss of potassium. Here if you see the urine potassium, it will be less than 20 milliequivalents per liter. So it is very important to test the urine potassium. Whenever you are seeing a hypokalemia case, you have to always look for urine potassium. We have to see whether the potassium is lost through the kidneys or some other reason. If it is lost through the kidneys, we have seen the reasons like Conn syndrome, Gitelman syndrome, Bartter syndrome, all these things that we will see afterwards. We have already seen the slide previously. Urine potassium, if it is less than 20 milliequivalents, that means the potassium loss is not through the kidneys, it is either through some other route or redistribution of potassium, or patient has not taken adequate dietary potassium. So the major causes are vomiting, diarrhea, nasogastric aspiration and increased sweating. In that, vomiting diarrhea is one of the common cause for this hypokalemia. Renal loss of potassium, urine potassium is more than 20 milliequivalents per liter. Diuretics, the major cause. So many patients on hypertensive therapy, if you are putting the patient on diuretics, you can see that hypokalemia occurring. And remember, hypokalemia itself can increase the BP. So we have to be very careful. If the patient is developing hypokalemia, change a diuretic which has got potassium sparing action like spironolactone. Osmotic diuresis like mannitol, glycosuria. So increased blood sugar also can produce increased loss of potassium through the kidney. Hyperaldosteronism, mainly aldosterone producing adrenal adenomas, can produce potassium loss through the kidneys. Amphotericin B is a antifungal drug that can also produce hypokalemia. So whenever the patient is on amphotericin B infusion, we have to always check the potassium levels. Salt wasting nephropathies like Bartter syndrome, Gitelman syndrome, tubular intestinal diseases, Liddle syndrome. So all these things we have to rule out. So it is very important to see the urine potassium. If urine potassium is more than 20 milliequivalents per liter, then it is a renal loss of potassium. If it is less than 20 milliequivalents, some other cause has to be investigated. Now, healthy patient and primary hyperaldosteronism, you can see here. In aldosterone, when it is excess, increased levels of aldosterone, you can see sodium retention can occur, potassium diuresis can occur, volume overload along with sodium retention can occur, that leads to hypertension. So all these things are together called as, in primary hyperaldosteronism, Conn syndrome. So hypertension with hypokalemia. If you have a patient who is having high BP, young patient with high BP and hypokalemia, urinary potassium loss, remember that can be due to Conn syndrome. If the patient is having hypertension, hypokalemia, increased potassium loss on diuretics, then it may be due to diuretics. So we have to always rule out diuretic here, because diuretic itself can produce all these changes like primary hyperaldosteronism. Renal tubular acidosis, it's a rare cause for potassium loss through the kidneys. In potassium wasting can occur both in distal type 1 and proximal type 2 renal tubular acidosis. Remember, most of the hypokalemic cases, if you take an ABG, it will produce metabolic alkalosis. If you are seeing acidosis with hypokalemia, always rule out renal tubular acidosis. That is very, very important. Then Cushing syndrome, steroid therapy, all can produce hypokalemia. Magnesium deficiency is very important when you are managing hypokalemia. If there is a magnesium deficiency, you have to correct that magnesium deficiency. Unless until you correct the magnesium deficit, patient may not recover from the hypokalemia. Now, all these potassium deficiency features are ultimately leading to muscle weakness, whether it is skeletal muscles or muscles of respiration, whatever it is, it affects the muscles. So patient develops acute flaccid muscle weakness, bilateral muscle weakness, like Guillain-Barré syndrome. Guillain-Barré syndrome is an ascending weakness. Here, all of a sudden, patient develops acute muscle weakness. Areflexic, bilateral, symmetrical muscle weakness is a classical finding in hypokalemia, and especially in hypokalemic periodic paralysis. So every 0.3 milliequivalents per liter decrease in serum potassium, total body potassium deficit will be approximately 100 milliequivalents. So you have already seen that 98% is in the intracellular space and only 2% is in the extracellular space. That's why 0.3 to 100 milliequivalents, total body 100 milliequivalents deficits will be there. Now, severe potassium deficiency can produce almost all types of muscle weakness, areflexia, rhabdomyolysis, myoglobinuria, renal failure, respiratory paralysis, paralytic ileus, constipation, urinary retention. Almost all types of muscles in the body will be involved. Now, there are cardiac problems because cardiac muscles also can get involved in hypokalemia. So cardiac arrhythmias are very, very common, especially in patients who is having patients is on digoxin. So patient can have various type of arrhythmia. If the patient is having hypokalemia without digoxin itself, patient can have different ECG changes. So there will be increased amplitude or width of the P wave. So wide and tall P wave, prolongation of PR interval, T wave flattening, and then it will become T inversion, ST depression, prominent U waves, that is very important. V2, V3, you can see these changes, precordial leads like V2, V3, you can see prominent U waves. Long QT interval also can be seen. So here you can see prolonged PR interval, wide P wave, wide QRS complex, ST depression, flat T wave. Then after T wave, you can see U wave. U wave is seen in V2 and V3 chest leads. Now, whenever you have a hypokalemia case, when you are evaluating that, always send a urine sample. We have already seen that urine sample, how important it is, because If the urine shows potassium more than 20 milliequivalents, then you have to see metabolic acidosis. Then if it is metabolic acidosis, renal tubular acidosis, acetosolamide, diabetic ketoacidosis. Extra renal cause, you can see vomiting, diarrhea, they are the major cause. And if it is metabolic alkalosis, again you can check urine chloride. If the urine chloride is less than 10 milliequivalents, vomiting, gastric drainage, diuresis. High urine chloride, hypertensive, that is very important. If the patient is having hypertensive and high aldosterone levels, it is due to aldosterone, hyperaldosteronism. In that patient, if the renin is high, then it is renovascular hypertension. So it is very important: hypokalemia, metabolic alkalosis, high urine chloride and high urine potassium. Hypertensive patient, high aldosterone level, it is primary hyperaldosteronism. High aldosterone with high renin, then it is renovascular hypertension. So you can diagnose a case of hypokalemia by these two charts we have shown here. So it will be very easy for you to make a diagnosis. Now, whenever we treat hypokalemia case, it is very important to calculate the total potassium deficit in body. So each 1 milliequivalent per liter deficit in serum potassium will be equivalent to 300 milliequivalents total body deficit. So that much we have to correct. So normal potassium will be somewhere around 3.5. If it is 2.5 means 1 milliequivalent deficit. So each 1 milliequivalents we have to give 300 milliequivalents to the patient. So that is the deficit calculation. That is that much potassium we have to give. Now potassium, if it is mild deficit, you can give potassium rich food like fruit juices, coconut water. Oral potassium chloride solution can be given. 15 ml contains 20 milligrams of potassium, and salt substitutes like potassium chloride salt can be given. Low sodium diet, potassium sparing diuretic like spironolactone can be given. So all these things can help to improve the potassium if the patient is stable. But spironolactone should be given only if there is a increased renal loss of potassium or increased water and salt retention. If there is no water retention, no need to give diuretic. Now, potassium sparing diuretics are always beneficial in a case of hypertension with hypokalemia. So you can give spironolactone 25 to 50 milligram OD or BD. The only side effect of spironolactone will be gynecomastia. If the patient develops gynecomastia, you can change to eplerenone. That is a drug which has got potassium sparing action. It's a diuretic. It's an alternative to spironolactone. Magnesium deficiency should be always corrected in a patient who is having hypokalemia. So that is a must, because hypokalemia alone will not be corrected. If you don't correct the magnesium deficiency, hypokalemia will not be corrected. Now, IV correction is required only if the patient is having significant ECG changes or muscle weakness or respiratory distress. IV potassium 10 ml 15% KCl contains 1.5 gram potassium, that equivalent to 20 milligrams of potassium. So each 10 ml contains 20 milligrams of potassium. Add 100 milliequivalents of that, maybe 5 ampules to 1 liter of isotonic saline infusion in this saline rate of 100 ml per hour. So that can be given, but the rate of infusion should not exceed 20 milliequivalents per hour unless paralysis or malignant ventricular arrhythmias are present. So that is very important. You can give potassium through the peripheral lines if it is less than 40 milliequivalents per liter. But if it is more than 40 milliequivalents per liter, and if the requirement is very high, always prefer a central line for this infusion. So central line is very important, because if you are giving large amount of potassium through the peripheral lines, there will be severe thrombophlebitis and burns throughout the hand. So better to go for central line. So use central venous catheter if the rates are more than 10 milliequivalents per hour, or if the total dose is 40 milliequivalents per liter per day. Do not give more than 240 milliequivalents per day. Repeat potassium level measurement every 1 to 3 hours. So the problem is in potassium correction, some patients may respond fast because they may be taking even oral potassium also. or sometimes lab errors can come. Initial potassium value may be low, abnormally low because of some error. So we have to be very careful in correcting hypokalemia, because when it goes to hyperkalemia, that produces its own complication, especially in patients who is having renal disease. So we have discussed about hypokalemia, one of the important electrolyte imbalance in emergency room. We should know the causes. Whenever we see a hypokalemia, always check the ABG values. Normally, hypokalemia produces metabolic alkalosis, or alkalosis produces hypokalemia, whereas a patient who is having hypokalemia with metabolic acidosis, always rule out renal tubular acidosis. That is one important thing. Always check the urine potassium. We have to see the potassium is lost through the kidneys. Urine chloride, whether any increased urine chloride is there or not. Then always check the patient's BP. If the patient is having high BP, rule out hyperaldosteronism. Check for aldosterone and renin levels, and you have to see whether the patient is on any diuretic or any AC inhibitors or ARB. All these things, they are also very important. So hypokalemia is an emergency. We have to manage. When you are giving large doses, prefer a central line for correcting this. Thank you.